Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
This is Dr. Candace Pierce with Elite Learning by Calibri Healthcare, and you are listening to our Elite Learning podcast where we share the most up-to-date education for healthcare professionals. Welcome to this series focused on a class of medication that's becoming increasingly popular for not only managing diabetes, but also obesity, the GLP-1 receptor agonist. Over the last decade, GLP-1 agonists have gained prominence as effective treatments that not only improve glycemic control in type 2 diabetes, but they also promote weight loss through appetite-suppressing effects. Major guidelines now recommend GLP-1 agonists as a routine part of diabetes management, but they're also popular now in weight management. So we're going to take a deeper look into the mechanism of action of these medications, and we're going to review that extensive clinical evidence on their cardio, metabolic, and weight loss benefits. And joining me for this podcast is Dr. Kathleen Woltz. Kathleen, welcome. Thank you so much for joining us.
Thank you. I'm excited to be here.
Yes. Can you share a little about yourself?
I am a provider, an NP provider, and I currently co-own 2 medical clinics, primary care, walk-in, urgent type clinics, and then also we own a medical spa. So we use GLP-1s on both sides, diabetics and non-diabetics, for weight loss.
So this will be a good conversation.
It is. Again, another passion, so much of people, especially women, so much of their identity is tied up in their weight. And this is such an empowering drug for women that I just can't tell you how it's been life-changing for most women that go on it. It is amazing.
Okay, well, let's start with, can you kind of give us an overview of the GLP-1 agonists, like how they work and their role that they play in weight management?
Yes. So the GLPs are receptor agonists that were originally developed for the treatment of type 2 diabetes. Sorry, I got my notes here, so I'm just going to be pulling up my notes just so that
that's
stay
okay.
on track. So they mimic the effects of glucagon-like peptide 1 hormones. So they increase the feelings of fullness because they slow gastric emptying. So food stays longer in your stomach, so you're not hungry. And they also increase the incretin hormone. So that hormone makes you satiated. So in your brain, it tells you you're not hungry also. So those 2 things work. The nice thing about a GLP-1 is it doesn't really affect your blood sugar. So it only affects your glucagon stores. So you're not you wind up not having to worry about things like hypoglycemia, liver issues, those type of things. So it's kind of a safer drug. And there's there's multiple on the market. They're GLP-1s, and then they're GLP-1s with a GIL, which is the Mounjaro, the Zepbound, the tirzepatide. So it's like a GLP with a little added influence
Oomph to it.
Yeah, a little oomph.
Okay. So what are the ones that are approved for weight loss?
So for weight loss, the only ones that are approved currently are the semaglutides, which is Wegovy or Ozempic, and then the tirzepatide, which is Mounjaro. It was approved last August, October, somewhere like that. And that is Zepbound. And those are the only 2 that have really been approved. Rybelsus is an oral form of semaglutide, and Rybelsus works by is an oral form. The problem with Rybelsus is it works really well in diabetics. In order for it to work in weight loss, it takes a lot more of the drug, and then because the drug is broken down in the stomach with the stomach acid. So it's kind of people are using oral semaglutide, but they're really not getting much of an effect for it. For weight loss, it's a very, very good drug for diabetes, though.
So how do these drugs compare in terms of their efficacy and their side effect profiles?
They're actually, surprisingly, they're very safe drugs. They have a very good profile. So what happens with is that sorry, I'm just trying to get my notes back. So they have done a series of studies on these meds. I don't think people realize how well studied these medications have been. So originally, the first drug that came out was semaglutide or Ozempic, and they used it in diabetic patients. And what they found out was that not only did they get good control of their blood sugar without the risk of hypoglycemia and a lot of the side effects, they also had a really significant weight loss of like 20%. Well, we all know the biggest underlying cause of diabetes type 2 is being overweight and becoming insulin resistant and all that. Well, now there was a drug that was going to address that, but also is addressing the weight. It's kind of like the Viagra. Viagra was originally, created for pulmonary hypertension, and then they had a side effect. Same thing happened here. So the drug itself has been around for a while, used with diabetics. And as I always tell my patients, you have to understand, and anybody in healthcare gets it, nobody's body is more messed up than a diabetic. It affects every organ in their body. So no matter what spot, it's been touched by diabetes. And there's a lot of complications for diabetes. As nurses and providers, we all know that, they're their own complex patient. Right. So this is a drug that's made to be used for somebody with complex illness. So first of all, it has to be a pretty safe drug because you've got a lot of issues going on. The other thing is it's been very well studied. They have done a step study which looked at the weight loss. And in GLPs, the weight loss is usually around anywhere between 15 and 25%. It's significant. Yeah. They did a series study that looked at cardiovascular risk. They found out there's no higher risk in patients that are on a GLP-1 versus a patient who's not on a GLP-1. They looked at cancer risks, and they found there's no higher risk of cancer on a patient who's been on a GLP-1 versus someone who's not on a GLP-1. They're continuing to do huge studies on dementia, addiction, renal disease. They just came out recently, Medicare did, and say they will pay for the GLP-1s and GLP-1s, GILs to be used on patients that have diabetes and heart disease. So even if their diabetes is under control, we'll pay for it because of the protection of heart disease. It's a very good drug. There are indications, though, where you can't take this drug, okay? So you cannot take this drug, of course, if you're pregnant or nursing. It's not going to happen for weight loss. That may change down the road, but right now that's a no-go. History of medullary thyroid cancer. So medullary thyroid cancer is a very rare form of thyroid cancer, but it does occur. So they did the initial studies to look at the safety and efficacy of GLP-1s. They reproduced it in rats. Okay, there's never been a patient who has developed medullary thyroid cancer. It has just been done in rats. And I think it was only one rat. But they have that warning on it. And then also if you have pancreatitis or if you have had pancreatic cancer, the pancreatitis, though, is loose because we had a patient that was schizophrenic that was on the antipsychotics, the Geodon and stuff, which gained tons of weight, and on Depakote, which then the patient developed pancreatitis because of the Depakote. We work very closely with an obesity specialist. And so we called him and said, hey, can we use a GLP-1 even though this patient had pancreatitis? He said, absolutely. That was cause and effect. There is no reason why you would reproduce this. So, and we did, and it was 100% successful. I also use it cautiously in other conditions. So if I have a patient who has lupus, or I had a patient that had chronic lymphocytic leukemia, or I have a patient who has IBS. I had a patient who had Crohn's. I had a patient who had a fundoplication. I will tell them, because it affects the GI system, these are all issues that potentially could occur. And then what we do, or what I do in practice, is I send them back to their primary or their GI or their oncologist or their surgeon to get clearance first. And I've never had anyone refuse the medication as a specialist. They've all approved it without any problem. So be aware that there are issues. I also will not treat anybody under the age of 18. I feel if you need to be treated with a GLP-1, either for obesity or diabetes, you need a specialist. You don't need me coming in. And of course, you can't use it for type 1. It has to be type 2 diabetes. So,
right. Absolutely. So, these are becoming more and more popular. More and more people are getting on them. And so this is just a random question, but do you know like the cost of using these? Like what is the cost for the patient? Is insurance step in?
Interesting. Again, as we have talked earlier, we are in the market. We are in the market of disease fixing, not the market of disease prevention. So unless your hemoglobin A1C is 6.5, and it doesn't matter if it is 6.4, you are 300 pounds overweight, you have NASH, you have GERD, you have a 50% occlusion in one of your coronary arteries, you have PAD, you have everything. If your hemoglobin A1C is not 6.5, it can be 6.4, but if it's not 6.5, your insurance will not cover it. The cost without insurance, you can go on GoodRx and check it out. It's usually around $1,300. It's between $1,200 and $1,500. The tirzepatide, the Mounjaro, Zepbound is more expensive. So what has happened?
And that's for like a month?
It's a month. It's a month. So this is what's happened. So when the shortage first came out, because the drug company was like, wow, we're sitting on a gold mine. And the FDA was like, hey, you're sitting on a gold mine. But there's a lot of people out here that need this drug for obesity. Oh, just think if you cured obesity, what you would cure disease-wise. You would take out hypertension, diabetes, joint replacement. They predicted all joints, there'll be no more joint replacements within 5 years if this drug was open to everybody in the United States. You're going to take away cancers. So many cancers are connected to obesity. I mean, just think of the diseases that go away when obesity goes away. So the FDA came out and said, look, we can't do this. You can't like hide this from all these people. You're years away from a generic. So we are going to allow compounding pharmacies to create this drug. So they took the medication, they gave it to, they took the recipe, they gave it to the compounding pharmacies and said, you have to create it, but you have to add something so it's considered a generic. So what they did was they allow compounding pharmacies to create it. This, though, created a whole nother problem in the area of weight loss. Okay. So because of that, I have a whole thing that we do about compounding pharmacies. I don't know if you want to do this now.
Yeah, let's go.
Okay, because I also want to touch on this point real quickly, though. For people that are on Medicaid, public aid, sometimes it's a little bit harder to get this drug approved, even with a hemoglobin of 6.5. So then we have to use a drug called Trulicity, which is not as good weight loss wise as semaglutide or tirzepatide. Or we'll use Saxenda, which is a daily shot. So Trulicity is a weekly shot. Saxenda is a daily shot, the liraglutide. It's just not as good as the tirzepatide and the semaglutide, but insurance will always go with the least expensive one. So I just want to put that out there. So the way I do it is, and there's a lot of ways to do this, and you can make a whole lot more money than I do. So if you're looking to make money, I'm probably not the person to talk about because that ship has sailed for me some reason. But basically the way we did it was we decided we were going to do this in the most safe and efficacious way we could. Okay.
Right.
Money is nice. And believe me, I'd like a ton of it. But we had to make sure we had patient safety as the center of all that we've done. So what we did was I went ahead and I found compounding pharmacies that followed the recipe exactly, because what's happened is they're substituting things within the recipe. So one of it is salts. They're using salts and that changes the recipe. It's kind of like if you have a recipe for almond flour, but then you use coconut flour. Does it really change anything? I don't know, but it's not following the recipe. And we wanted to follow the recipe because, we have a lawyer that's one of our owners. The other thing we did was we vetted them. We went to compounding pharmacies and we vetted them and said, I want to see your solvency records. I want to see your potency records. I want to see your accreditation from your state, for your board of pharmacy. And I want to see any FDA products you use, because FDA does not approve or does not accredit compounding pharmacies. However, both of my compounding pharmacies only use FDA approved products. So the chemicals are FDA approved, the vials are FDA approved, the hood is FDA approved, the manufacturing is FDA approved. So that's how we vetted ours. And so we only use 2, and they're not they're not the cheapest by any means, but we are 100% convinced this is the safest and efficacious way for us to deliver the drugs to our patients. I think what we're seeing a lot of is a lot of people are jumping on this bandwagon that have absolutely no reason to be on it. They're just looking to make money. Costco has just entered into the world of semaglutide. And so now you can just go to Costco and pick it up. So how they're doing it, they're really undercutting the price. How they're figuring it out, I have no idea. But for me, my patients have a consultation. I sit down with them for 1 hour and go through a 5-page list of things. And we'll talk about more of that. I go through how to deal with the side effects. What are the side effects? How to dose it? What to do if you miss it? Like frequently asked questions. I go through all the consents. And then when I'm all done, I send them home. I tell them I'm going to email you all the information. Take a week. Think about it. Make sure you're 100% committed to this. I give them the names of our compounding pharmacies, their addresses, their contact information. Tell them, vet them yourself. Call them. Check with your check with the College of Pharmacy in the state of Illinois, where I'm at in the Midwest. Check it all out, and if you're comfortable, come see me. So currently, what we charge a client is we charge $400 a month, or $400 a vial for semaglutide and $600 a vial for tirzepatide. You buy 2 ml vials. The vials come in 200 units per vial, and you dose according to units. So the vials last according to your units. So if you start on like 5 units or 8 units, a very small dose, so that initial vial will last as long as probably like 10 weeks. As you go up, by the time you're at 50 units, you're going through a vial a month. So most patients don't get that high, but it's just kind of the number that we use. So, and we let them know all of this up front. And then I've had patients say to me, well, I can find it cheaper. Then go find it cheaper. I would rather you be happy and not be involved in it. I've had patients that have double dipped. Because I will tell you, this is a very powerful drug. And the reason why it's so powerful is that, I'm sorry, I am so passionate about this that if I'm getting over, then stop.
No.
The reason why this is so powerful is, as women, our body image is so entwined with who we are. And I know it shouldn't be, and I fuss with it every day, and I listen to my affirmations, and I tell myself all these wonderful things. And man, when I lost 10 pounds, I thought I was hot. And then I lost 20 pounds, and then I'm snatched, and then you lose, because what's happening is you're able to buy the clothes that you see everybody else wear. And you're all of a sudden, you can put them on and you look good. And when you look good, you feel good. And when you feel good, you do good. Do you know what I mean?
Yeah.
So it has like tied up. I mean, I have seen women just explode in confidence and in challenges and in moving mountains. And it's like, because they know on the outside finally reflects what they have believed on the inside, that people did not hear them. So, but saying that, it's also a very, very powerful drug in the effect that it gets highly addicting. Everybody comes in with the same thing. I only need to lose 25 pounds. If I can lose 25 pounds, I will be so happy. So they come in and they lose 25 pounds. And then they're like, another 10. I just think it's another 10. I think, I'm looking pretty snatched, but just another 10, just another 10. And then they get down that other 10 and then they say, when I was in high school, I weighed 100. And then you're like, nope, not going to happen. But it's just because the drug becomes so powerful. It stops the food noise. It just stops. So you're not dealing with this, eat those cookies, get that chips. I'm hungry. Oh my goodness, there's some Reese's Pieces. I'll eat the whole bag. It just all goes away. And you really focus on the more important things like how to eat well.
So how do you identify your candidates, the appropriate candidates for this?
Okay, so I have them come in. So we use BMI and we use BMI and we also use weight. Most of my patients that are coming in need to lose, 30, 40 pounds. Some of them need to lose a couple 100 pounds. So normally what you would say is if they are overweight, we try to use a BMI of 30. But, there's a lot of other things that go in with that BMI besides a BMI of 30. And then we also will do a BMI of over 27 or over if they have comorbidities. So if they have hypertension, if they have some insulin resistance, if they have some PCOS, just if there's some other issues going on, we'll also use that. Rarely, you can identify if somebody's looking that may have some other underlying issues like an anorexia. And you really just don't go down that road. You know what I mean? It's pretty simple most of the patients really want to lose, that 20, 30, 40 pounds. So I've had patients that want to lose 10 pounds and I told them this was not worth it. You do not want to do this for 10 pounds, and so look at something else. Look at phentermine, look at Contrave, look at topiramate. There's other drugs that you could use for 5, 10 pounds. You don't need this drug. So it has to be more of a substantial weight loss. Again, we look at patients that have really select clients that have the comorbidities. We make sure that they aren't addicted to food, because one of the things we have to think about is if they are addicted to food and we remove that food addiction, we're going to get a massive depression. And we have to be very cognizant of that. And I think what's happening a lot because this drug has such commercial value, we forget this is a drug. This is a definite prescription medication and needs to be treated as a prescription medication. So our conversations with our patients have to be honest, they have to be forthright, and they have to know what the parameters are. You lose too much weight or you don't follow my instructions of exercise, eating correctly, limit alcohol, you're off. And my own sister's on the drug and she lost a lot of weight. And I said to her, I'm taking you off this drug if you don't eat. Cause she said, I haven't eaten in 3 days. I said, well, then you're done. She's like, you can't tell me that. I said, oh no, I can. Do you know what I mean?
Yes.
And because you can go extended periods without eating, but then you're going to open another bunch of issues. So we have to be good stewards of this medication. This is not just about commercial value. This is about safety. And so I am very, very, I make my patients, I see them every month. I weigh them, I measure them, I have conversations with them. And I've fired 3 people from my program. I have no problems firing you. If you're not going to follow the rules, you can go somewhere else and get it. Do you know what I mean? I'm not going to be responsible for your kidney failure or something else that's going to happen to you. I don't want to be the person.
That's really good to be good stewards of this medication. So when you are counseling your patients, what are the potential side effects and how do you help them work through it? Because I know some of the ones I've heard are like nausea and just some GI issues.
Yeah, it's mostly GI. So what I do is after I sit them down and I talk to them about, this is what the drug does. This is the studies on the drug. This is what we're hoping to see from you. Then we go through like frequently asked questions. So usually their questions will start with side effects. One of the things is you've got to stick yourself. It is a self-injection. I do have a patient that comes in once a week for an injection, and that's her choice. But we start with 1 injection. So you get 1 injection either in your abdomen or your thigh. You can do the back of your arm, but that's a little hard if you're doing it yourself. And then they say, well, you can get a irritation at the injection site. Some people will do it,
Right.
or they'll get a lot of side effects. So then what we say is then divide it into 2 shots. So far, nobody's done that yet, but you could take 1 shot and divide it into 2 shots. It will
Yes.
minimize irritation at the injection site, as well as also stopping some of the side effects. So we try that, we offer that. We talk about weight loss. Your weight loss should only be 4 to 6 pounds a month. It should not be more than that. If you lose too much weight too fast, it's going to throw you into a gallbladder attack. I mean, and that's true whether you're on Noon, Weight Watchers, bariatric surgery, no matter what it is, you lose weight too fast, it throws you into a weight loss or into gallbladder attack. So we talk about gallbladder. We talk about if they're at risk, they have sludge or anything like that, it's going to make them more prone. We tell them no more than 8 pounds a month, that you really slow and steady is the way to go with this drug. Don't think you're going to start this drug in May for your wedding in June. It's not going to work that way. So we're very good about that conversation. We talk about, again, how the vials last. We talk about when they should see results. So they'll see some weight loss within 2 to 4 weeks, which then makes them feel a little bit better. We talk about the biggest side effects. The biggest side effect is going to be GI. You're absolutely right. Nausea, vomiting, diarrhea, constipation, epigastric pain. The weird thing is, anybody who's ever been on this drug, the nausea comes out of nowhere and it hits you like a ton of bricks. I mean, you are so nauseated. You think, oh my goodness, I'm going to vomit right here and then. If you breathe through it for about 20 seconds, it will go away. Okay, it's very fast, but it is hard when it hits. My funny story is I'm a runner and I run races all the time. I've never thrown up in a race. Every time since I've started this drug, at the end of every race, I vomit. I've never done that before. And I think it's because the food sits so long in my stomach. Where before it was empty. But that's like I come over the finish line, I vomit. So now I come over the finish line and just look for a garbage can. It's the weirdest thing ever.
That's very interesting. Oh man. Gastroparesis. I've heard like maybe on the news or, sometimes you see it on social media, gastroparesis talked about a lot with GLP-1s. Is that a thing?
It is. It's occurred. The big side effects that we worry about are gastroparesis, we worry about ileus, and we worry about a bowel obstruction. Gastroparesis is how the drug works. It holds things in your stomach longer, which is technically gastroparesis. So it's kind of the way it works. There has been evidence that showed that when you went off of it, that stayed. So that's an issue. The ileus and the obstruction has been found in a very minute number of clients. I think the most important thing is for everyone to realize that this drug is being used by more and more people. It has gone to the masses. I mean, it is estimated that there's like 300,000 to 500,000 people on this medication. Okay. Almost every nurse you know is on this medication. It's, I know so many nurses that are on it, but, a lot of people are on this medication. So as it keeps going to the public, we're not hearing any more about side effects. So that's a good thing. And there are other side effects that we can talk about in the remainder of the next part of the podcast, because there are some other side effects that we need to talk about.
Absolutely. All right. Well, that's going to wrap up our first episode of this 2-part series where we're exploring the important role of GLP-1 agonist medications and what they play in obesity management. We've covered a lot of ground. Just here, we are discussing, the mechanism of action of the drugs. We've talked about, some patient selection criteria that Dr. Wolf's used, and really getting, kind of starting to get into the strategies for initiating therapy. So in this next episode, we're going to continue this discussion on monitoring patients, and I think there's some more things to cover in initiating therapy as too. Do you think, Dr. Wolf?
Absolutely.
All right. So thank you for listening, and we look forward to continuing this important discussion on leveraging the full potential of these GLP-1 agonists.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.
Thank you.